attention that Parkinson Society BC would like to invite you to join us for the 31st annual Parkinson Super Walk this summer. And Super Walk is the Society's largest fundraising event, and it helps fund our event programs, support services, and advocacy efforts. And this year's event will be hosted virtually with opening ceremonies taking place on Saturday, September 11th. And so if you want to learn more and register, please visit our website at www.parkinson.bc.ca/superwalk. I'd now like to introduce our guest speaker, Dr. Brenda Lau. And Dr. Brenda Lau is a pain specialist and anesthesiologist practicing in Vancouver and Surrey, BC, with over 20 years experience in both. She is a fellow at the Royal College of Physicians and Surgeons of Canada and fellow of the Faculty of Pain Medicine of the Australia and New Zealand College of Anaesthetists, after completing a 2-year pain medicine fellowship and Master of Medicine degree in Sydney, Australia, subspecializing in interventional pain management and multidisciplinary team care. In 2013, she co-founded ChangePain Clinic, a Vancouver-based pain center that provides multidisciplinary pain care for myofascial, spine, neuropathic, complex regional pain syndrome, headache, pelvic, visceral, post-surgical, post-trauma, chronic diseases, and post-cancer. She and her team specializes in the prevention and early recovery from injury. And Brenda is passionate about resolving chronic pain through therapies supporting prevention, rehabilitation, and early recovery after injury. She has led numerous national, provincial, and hospital-based initiatives to improve understanding of pain, improve pain treatments, and improve pain care training. Dr. Lau, welcome, and thank you for being here today to share your expertise with us. I will now pass it over to you.
Thank you so much, Elena. Just checking in, is there any feedback there or not? Sound coming through clear? All right, excellent. Everyone, I'm so excited to join this most important series, just having education, sharing new knowledge amongst, and I learn as much actually from all of you as I hope that you're going to learn some from me as well. So I really thank Shelley and Alana for their invitation today. So there was a handful of things that Alana had mentioned, but in summary, we do treat and see a lot of different types of pain patients head to toe. This talk today, I'm going to use the PowerPoint as a bit of a guide, both visually, but also it kind of helps orientate us to, what's available not only at our clinic, but just in general for patients with Parkinson's disease, and to kind of wrap our minds around what seems to be a lot of different areas that can be affected for those with pain. So I'm going to use that, but we of course encourage you to use the chat on the side, and I'm watching all the questions that come through. I may be batching them so that I might unshare the PowerPoint and address them right off the bat, or just do it right at the end where we can really have quite the discussion. All right, so I'm going to just share a screen right now, and you are going to see this PowerPoint first. I'm just going to do a check-in that everyone should see that screen. I'm going to play this from the start. All right, everyone. So this is going to be focused in on pain in general, but also what is available now in BC. This is picture of our current lounge when people just step into the clinic if you haven't been here before. I'm hoping to cover in the next an hour the general idea of what we understand the pain experience to be with our Parkinson's patients. And also what's the typical journey that you could expect if you came to a clinic like ours, which is a multidisciplinary clinic. So again, I share with you what we do here, but a lot of other clinics around BC is trying to uphold those components as well. And then the question is, if you do come here, how do you really make the most of it? In particular, really want to look at those strategies that you can utilize at home and anywhere, not just because you're with the doctor and the team. And of course, some new thoughts, especially in the scientific literature, around services that are in fact not provided here at this clinic, specifically for our Parkinson's patients. Okay, everyone, so types of pain experiences. As you can imagine, just because you have Parkinson's doesn't mean there's a specific type. Also, from head to toe is a plethora of different syndromes. Ford and Group in 2010 kind of best described it. He really broke it down into the general muscle skeletal, so soft tissue, bony, and joints. Then he went into the neuropathic radicular, meaning the sensitizations related to nerve, either pressure, compression, narrowing, and just the development of neuropathic pain in general because of sometimes the drugs like levodopa that are being used. But then there's something that is what we call central, meaning that it isn't just one body part. In fact, it's multiple different parts of the body involved. And this is very much, for example, where it's related to other types of symptoms like heart rate being increased, other kind of autonomic features like that. So someone who's had stroke, for example, can present with a central pain that no longer is only the pain of the arm from the arm itself, but it's actually the area where the stroke was. So central is really pain signaling derived from within the brain itself. And then, of course, there's everything related to just because the movement is more stiff. And in fact, because of that, it will impair some of those other aspects of the body. So that's why the second point and third points here is that you can't just say, oh, there's only this one type of pain. It really depends on disease stage. It depends on the other things that you're dealing with. Maybe you've got heart disease or you've got a vascular condition. So again, when we look at pain on its own, but pain within Parkinson's, we look at it like an onion layer by layer. So we look at the body level. Is it the skin? Is it the muscle? Could there be nerve compressions? So no different. But then we layer on what the movement patterns are that can in fact cause some of those compressions that are different than someone who just has the average low back pain. And of course, medications and the medication side effects. So that's how we start thinking about it. The other layer that we really think about it that maybe other clinics not emphasize as much is at the nutritional level, antioxidant level, your chronic inflammation level. And so people will know things like ibuprofen and those anti-inflammatories, but we're talking deeper at the level of your immune system. I'm going to go into that shortly. And then in the last kind of 3 points here, in particular, the neuropathies are a really big deal. Apparently with very high dose levodopa, just like with a lot of the other medications that are anticonvulsants or kind of antidepressants, these nerve-related, brain-related medications at very high doses will alter pain signaling as well because they really do use very similar neurotransmitters. And finally, it's pain related to many other problems that people face, meaning problems with sleep, problems with depression, mood issues. So the pain isn't caused by that, but is very much aggravated by that and your ability to recover. So again, there's many types of ways that we deal with pain. So here's a summary. Again, really busy, a lot of studies. But the more recent studies were really, again, just trying to divide up, like, is there a predominance of pain? And there's no doubt, dystonia, any of the musculoskeletal are really the highest percentage of pain affecting Parkinson's patients because of really the muscle rigidity. But really coming a close second is what I call the neuropathic, because anytime the muscles are too tight, you can appreciate all the little nerves that pass through the muscles. They have problems conducting themselves, sending signals. So that becomes a misdiagnosis. And again, just this big summary again of what Alana already said, we don't turn anyone away. It's from head to toe because we know all of these are intermixed. You come in with one, you often have some other areas that are involved as well. Visceral is a big one with the abdominal issues at hand causing inflammation. So I'm going to come back. What does it look like in our clinic services, which I'm trying to highlight is the elements of multidisciplinary care. Now, for some of us, just a single, needle in one muscle, maybe that's enough. But often in our Parkinson's patients, that's not quite enough. Although you want to start with some of that if the muscle rigidity isn't quite alleviated with medications. But here's your typical journey. So that before I go into anything more, I just want to point you to this resource because I might be covering so much information that people, it takes time to integrate. So if you need more information, this is the best place to kind of help you walk through all the things I've talked to you about, in particular, the frequently asked questions. And if you need to actually use the Contact Us webpage is the best because there are just thousands of phone calls that come through that doesn't allow you to get through easily. So multidisciplinary approach doesn't necessarily mean you need 20 people involved with your care. However, we do need to take this multimodal approach at pain. So let's take arm pain, right? So here, let's say that it's very, very difficult to treat. You've done your massage, you've done some physio, but we've got to now look at all of these other elements. Why isn't it responding? So could it be that nutrition, the elements of the muscle, maybe it's the inflammation that's being stimulated in the muscle that's causing this. Maybe it's nerve system. So that's why that pedal that talks about relaxation isn't just about chilling out. It's actually about the autonomic nerve system. And as we know, there's some derangements in that already. So how do we rebalance that, especially through this nerve called the vagus nerve, right? In the same arm pain. And we think about mental health because it's not just that we have to treat the pain here, but how is it that it now involves your sleep? It involves, what you're able and not able to do. So it's all those things that now, takes a bigger picture of the abilities rather than just the pain itself. And of course, movement. What is obstructing the movement? Is it really something, let's say, at the elbow joint, or is it really just the muscle features itself? All those things can be mobilized potentially with procedures. And finally, we never think about any person with pain outside or on their own. They're always embedded in community with their school, their work, their families. So all of that needs to be considered. So with that in mind, here's what a typical journey looks like. So it's the medical journey. So medical services plan, MSP, will cover several things like your consults, certain procedures, your reviews, maybe medication involvements, etc. They cover those things. And now since COVID, that bottom line down below, the blue line called group medical visits, we've been able to explode out the access to our team through online. And so even when COVID isn't such a huge impact anymore at some time soon, we hope that this stays because this allows the greater reach across the province to a multidisciplinary team that some areas don't have. But in this journey that you can see, we actually use, in fact, sometimes the procedure to really help us understand why is that muscle not working so well? Why is your walk stiffer than it should be? Or why is it that even when you're taking all your medications, you've still got this really severe low back pain that affects the buttock lower side? Is that an entrapped nerve? Is that a joint? Is that a disc? So again, these procedures are part diagnostic, but they also help to see how you respond. Because I let you know that I have treated headaches by releasing someone's calf muscles. And I would never know that unless I'm listening to the response, what they're getting, what they're telling me feels tight, or what triggers off their headaches. These are the ways that we help to tease out the mechanisms behind your pain. These next couple slides just kind of help to show you what's MSP and what's not. A lot of people get confused that the medical system should cover everything, and they don't. And here are things that they do cover. For example, advanced therapies like radiofrequency, but only certain parts. That's why I've got here that, there's certain medications like the steroids need prescriptions, or there's upgrade fees for certain MSP procedures, even if you're having to use really fancy equipment to get at it, and that's not what's normally covered. But you'll see down below, there's some really advanced things that MSP hasn't caught up with the science yet. prolotherapy, PRP for severe knee arthritis. For your neuropathic pain, you've got infusion therapy. For some of your migraine headaches out there, we have Botox, or for even spasticity, when, as mentioned, rigidity is not overcome with levodopa. And some of you might have even gotten into motor vehicle accidents. And so as of May 1st, there's some really interesting access now through ICBC for medical therapies, because typically they cover our allied health. And so again, orientating you to pain services. We hope that pain services in general always include movement specialists or chiropractors, such as our Dr. Wright, physiotherapists who are actually pain trained. If you're dealing with, let's say, surgical issues, you want to have, your movement therapist involved early, even before surgery. You might need, in fact, kinesiology to help with your program and really watch how things are going. Some of you are maybe doing just fine, but you need someone to boost your exercise to the next level. Maybe it's cardiovascular, maybe it's muscle building, maybe it's something different, but that you might want to maybe seek out an exercise physiologist. And others may need things like pain coaches that interact with both the sleep or maybe yoga components, etc. So there's a lot of different ways to get movement or strengthening cardiovascular training differently. So going back to this journey, we always encourage, don't just take the MSP approach. Wherever you can, you want to marry the allied health, the movement, always continuously for life. And just one plug in there. Know that if you do one set of exercises and you've done it for more than a couple months regularly, you really need to continue to step it up. Never feel satisfied when you've done something, because what happens is that your body gets used to it. It doesn't derive the same benefits. Now, I'm not saying that that walk for 30 minutes is useless. Not saying that at all. It's always good for you. But to bring up the health benefits, you always want to take it a little bit more. You might want to do breath work with that walk. You might want to build on muscles now. You might want to do those things differently. And that's why I highlight to you that you really want to consider having a consultation with those who can build up your program to the next level. So typically at ChangePain, we then at the end of this kind of thing, kind of wrap up, let's say over 12 months, and kind of see what's available to us. So how would you make the most out of our services or anyone else's services? And this is the realm in which self-management, which I hope many of you have heard about before, which is really what you can do to make the body's response best. And so I'm going to put a question out there, actually, because I'd like to hear responses. I don't see all the chats coming through right now until I unshare my screen. But my question to all of you is, what do you do currently for self-management? And if you don't do any, are there areas that, aside from pain, that you struggle with, or that you've maybe needed to talk to your doctor to, but there really hasn't been a lot of time to talk to them about? Maybe put some comments in around that, because I'd like to raise it up in discussion. While you're thinking about that, this is what we've done. I'm just highlighting right now that a lot of these right now are through virtual appointments. And just to highlight right now is that we've done this now to maximize the self-management work through MSP. And this last point is around the group medical visits, because as your physician, I have such a limited time that there is so much about the self-management work that isn't enough time to get covered in one medical appointment. So that's the reason why we've made this. And this gives you an idea of the breadth of what self-management could look like. So for example, let's say you're a veteran. So we had a veteran series. We have an entire 8-part series on the neuroscience of pain. And you kind of think, well, is there really that much to learn? And there is that much to learn. And 8 parts is just kind of getting the real pearls in there. Because when it comes to a lot of flare-up pain or depression or sleep problems, or what if you and your partner sleeps differently, and that's probably adding to your inability to recover well from injury, all of these things need to be looked at. Then you look down in the middle of this section, you'll see that we've got a lot of yoga in there. So again, different people have the different abilities to do yoga, and some are super gentle like yin, and some are really high energy like the kundalini. So again, movement is a huge part of what we do. But therefore, our physiotherapist, our chiropractor, does whole sections on the health of the shoulder, on the health of the hip. So even if you didn't have hip pain, you would want to consider taking those to understand the physiology of caring for those areas. And you'll see even going down, some of you who have widespread pain, multiple areas, you might now have a phenomenon called central sensitization. And so this isn't just your normal muscle rigidity pain. This is really high sensitivity to movement, to pressure, to even light touch. So these many different sessions right now offer components of what you can do at home, what you do with temperature, what you do with your immune system, your nutrition in particular. And I understand that last week or the week coming up, there was meant to be a talk around nutrition, and there's such a wide topic on that I do want to have some interaction around that, especially around boosting the power of your immune system, especially to COVID vaccines or otherwise. But anti-inflammation, antioxidant capacity in your body is huge. So again, as a physician, I don't have enough time. But if, for example, you took my brain health series for life, which is another 8-part series, you will hear us talking about those things. Finally, a way to optimize our services, which is a little bit separate than just self-management, but this is just highlighting to you that clinics like ours will often have things like research studies. So for any of you who might be undergoing surgery, or your doctor says, oh, maybe you shouldn't be having surgery, you should contemplate joining things like this. And this is optimizing your body, optimizing your breath, optimizing nutrition before surgery, so that when surgery starts and that area of recovery requires a lot more intentional work on movement, on your microbiome of the gut, all those things to accelerate healing. So this is just, again, part self-management in the sense, if you're aware you're about to get surgery, this is something that you might want to take up proactively. So this is my almost my final slide in the senses of in general, when we're thinking about what services are available. So for pain in general, there's MSP, various things. So there may be ongoing medical management. And there may be certain procedures that are appropriate, nerves, facet joints, joints in general, and muscles and ligaments, maybe headache or even the bowel issues. And then there are private pay types therapies that may be necessary. So advanced neuropathic infusion therapy like ketamine and lidocaine. Maybe severe depression needs ketamine itself, and that's private pay as well. But then there's also private pay allied health. And you might not need to see a physio 3 times a week, but you might want someone to develop out a program for you that keeps you advancing your overall body flexibility and health, every 2 to 4 months, for example. Then, of course, your GP is your key service. But down in the bottom, if you haven't heard, there's something called Pain BC. So Pain BC is an organization, which is a charity that we have created about 15 years ago. And here is where we try to keep up all the latest services across the provinces, including that green button on the side. And that means that, various pain services go up, they go down, they may only service certain things. So Pain BC has been one of our biggest go-to organizations to keep you up to date on what's going on. And so that's a huge resource for you to keep in mind. And on there is even, for example, when you call their line, because it never used to be, but in the last 2 years, because they were able to get some recurring government funding, they now have social workers on their line where, let's say you're looking at, where's the nearest resources for, low cost organic food? What about, is there help for housing, financial supports? Where's the nearest clinic that does PRP? They'll go through and answer all those different types of things. Or if they don't know, they'll point you to someone who does. All right. And then finally, on my last slide here, before we get into some more discussion, is in fact, what else are they thinking about at the scientific level? So some of you may, of course, be benefiting from something called transcranial magnetic stimulation. Those big words here, the acronym is usually TMS. So TMS is offered, it is basically, it's a magnetic waves that alter the actual brain neurotransmitters. And so for some people, interestingly enough, rigidity can be helped with this complementary therapy to your medications. So normally this is private pay. But for example, at UBC, they have a transcranial magnetic facility along with research studies, and they're just starting to open that up right now. And so that's either no cost or very, very low cost. And so you would look that up, for example, TMS at UBC. But others also offer it, whereas 2 years ago, this was not even available in BC. And then there's these discussions around spinal cord stimulation. And for those of you who are not familiar with this literally means like electrodes, like a pacemaker, and it's attached to a pacemaker box. In fact, they are using the same battery. But these different electrodes can be placed at different parts of the brain, in particular, deep brain stimulation, or in this case, spinal cord, to actually help change the signaling towards the muscles. And they found in some people that may be very helpful with rigidity. And that's why that's not, as far as I know, not that available unless you go through a neurosurgical consult here. So again, food for thought, if that's something that's necessary. Now, this last one's very interesting. I would say that there must be at least 5 hands up in our audience who knows about the microbiota or the microbiome, or what you call the gut-brain health. And this has been taking off greatly in the last 10 years in terms of research, because we see its impact on the inflammatory system, and so, or the immune system. And so we know many of our neurological diseases, and Parkinson's included, is that there's always going to be an element of inflammation, maybe to begin with Parkinson's, but also just rest of our chronic diseases. So by eating for our microbiome, for making sure the microbiome that gets maybe affected by things like antibiotics and surgeries, is that they now get recovered. So lots to talk about with that, and that's why there's a segue on nutrition. So I'm going to stop talking right now, because I see that there's a number of things on the chat right now, and I'm going to just start with some of those points. And of course, people to please still send more through, because I think there's also Q&A. I see 4 messages there. So I'm going to first start with Susanna. Susanna had mentioned here that her husband saw an ENT specialist about his pain inside and outside his throat, and they said there's nothing wrong. And could this be pain related to the Parkinson's? So without enough information, I could only say this is how we would approach it. So that's the first great approach. If there's something, let's say, focal to some area of the body, you want to approach the specialist to rule out what would be the most common things. Let's say there's infection, or there's a diverticulum pouch, or something, right? And if there isn't anything, that's reassuring, but then it doesn't really explain what's going on. So often what happens in the area of the neck and in the mouth, there are multiple different muscle structures. There's also many different nerves and blood vessels. And again, without knowing more details, especially if you've had any surgeries, or there's been masses, or even, let's say, enlargements of the lymph glands, maybe it's jaw muscles, or there's actual neuropathic pain, meaning, like, for example, burning mouth syndrome. It feels like you're always eating Thai chili. So again, depending on what that is, that's the onion layer approach that we would take. Is now that we're reassured that there's no cancer, and there's no, let's say, open lesions and like shingles in the throat, then we would go layer by layer to find out what exactly is causing that pain, Susanna. And of course, it always could be related, but most of the time, the Parkinson's pain can be a little bit more widespread and more musculoskeletal. In other words, of the actual limbs, or maybe the core and the back. When it's areas of the throat, or even in the abdomen, it's less so like just directly right to Parkinson's per se, but it could be a secondary spin-off. All right. So John asked the following. I have had the PD diagnosis for 3 years. He had a left total knee replacement about 3 years ago. He still has severe knee pain, and I'm assuming it's the same knee that you had the surgery in. But you could also probably have pain in the other knee, because usually if you have bad arthritis in one knee, the other one's also affected too. You've shifted to chronic, it's been chronic pain, and it really, in fact, just affects different spots on his knee. But at times, he even says it involves his whole leg, and the pain can be very sharp. It could be contractions. It could be achy even. Now, some of it he's currently managing with some medications, but he finds that it's really hard to walk every day, and he's very careful not overdoing it. Great that he's getting coaching. Wonderful. So good level of detailed information, John. I think you're not the only one. And in fact, even not with Parkinson's disease, if you minus your first line, that the rest of your section is so common that we see. So for your case, here's how I think about it. In the knee, there are, again, just like here, nerves, muscles, all those things. But particularly for the knee, especially after knee replacement, this is how we think about it. One is, first, the integrity of the prosthesis must be checked. Now, I'm going to assume, so let's say that hasn't been done. You want to take a look at that, because if it's not really in good positioning and not secured well with the cement, then it's always constantly going to move around. And that's why your leg's going to have a lot of pain, because now all of these other muscles are trying to support everything and it's not doing it well. So I'm assuming that all of that's okay. You don't have infection, you don't have a leg fracture, and your prosthesis is okay. I'm going to make an assumption now. And then now I think about the following. So in your knee in particular, so I'm going to kind of pretend this is like my knee here. And in the knee, when you bend it, there is this knee bone. There are 4 quadrants of the knee in which these genicular, or the knee nerves, feed. And sometimes after surgery, because they are very big cuts that go down the center, but they will stretch things out and they can cause what is called neuromas. So I have a nerve, all nerves are like this, but when they get cut, they can form these ends. Usually they grow back 1 millimeter at a time, and they eventually form a single nerve because there's a tunnel in which they grow back. But when they don't, they can cause these neuromas, and they're very painful because they're really these sensitive endings that are little balls at the end. And so therefore, we would think about those things. You might now need some diagnostic testing to see that's the case. We will often use things like this. I have ultrasound technology that allows me to look at those tissues in greater detail. And then we go layer at a time. And then finally, for me to put a plug in around this, the fact that it's so severe pain, but it's also the fact that it's spreading. So many reasons for that, because it has actually been now 3 years. Wasn't just yesterday. So the fact it's been 3 years means that you've been walking funny. The rest of the body has been really working hard to support you differently because you're not walking normally. And so you will get obviously just normal pain problems from bracing yourself differently. Okay, but the average physio may not be enough for that. Then there's second things where you talk about very specific points of your knee pain. Now, again, that might be tendon insertions. Those may be inflammations at those different points of those insertions, or it was those neuromas I was talking to you about as well. And then finally is that this spread, maybe this is where I talk about the private pain fusion therapy, that may be in fact good for some of the Parkinson's response, but it's also good for this wider spread, because sometimes, something happens right here, but in fact, the nerve messaging has been going up into my brain, and now the brain gets confused and it starts to spread the pain signals elsewhere. And so this is where we see a lot of neuropathic pain that isn't just following one nerve route. So anyway, the summary is that the way I approach, whether it's the throat pain by Susanna or it's John, we look at it layer by layer, and you can't make any assumptions. Okay. Then I see here, what is a brain health services 8 week? So what that means, Alana, is from Susanna, I think, or from Susan, is that we run these group medical visits. So right now, this is essentially a group visit. I am actually a physician now leading a group, and so they could potentially call this a group medical visit. I've actually, in fact, answered some clinical questions. So we do the same thing. We use the Zoom platform, but patients have to log in like a patient. So their PHN, date of birth, etc. But once you're in that diagram, in fact, I'm going to do the following. I'm going to share you a screen, which is my internet screen. And this is so much easier to answer this question this way. Oh, no, that's my actual PowerPoint, I think. Yeah, that's a PowerPoint. So that's not what I wanted. I wanted this one's what I wanted. Okay, so this will help answer, it looks like it's still pulling that up. Let me just see here. Let's go to a new tab. Hopefully you see a window. Yes, you should see this window right now. I'm just going to go to ChangePain. I'm just going to go into just showing you the actual website. I'm going to go into services to answer this question, but you can get in through this if you're just looking at MSP. So MSP, this is our groups. I'm going to show you the schedule. So the schedule is like this very busy schedule. And on Tuesdays, you'll see me host. This is what is called the Brain Health for Life series. I'm going to click that open and you'll see that I run this with a Brazilian neurologist, an 8-part series, and it goes into multiple different discussion points. So here it is. It's talking about when chemistry's off. So this is where mental health comes in, exercise and what happens to the brain, right? And it's not just what we're talking about, your basic motherhood statements on exercise. We're talking about chemistry. We're talking about optimizing brain function and what happens with play and creativity and tapping those areas, how to improve memory, sleep, nutrition, blah, blah, blah. So there's a lot of topics. And so what happens is that in not just that one in particular, but if you want more details on this, the details folder here shows you that where that chart came through, but this is where we're talking about. We now know that there's just so many things that people want to talk about that's not enough in a 5-minute appointment, 15-minute appointment. There's everything from sleep to veterans to all of the movement therapies. So hopefully that answers that person's question. And that's what that group medical series is about. And just as a little pointer, normally for the medical services, whether it's a consult with a doctor or it's taking the groups, you usually should get a referral from your GP or your doctor. However, because of COVID, you will see now on that schedule that some of our sessions are led by our GPs because we have specialized GPs who work with us. And because they're a GP and you sign into their session, you're actually open to take all of them now. You're approved to take all the other ones too. But typically your GP should be sending in a referral. All right, so someone else, John says, okay, so actually John's question, how do you initially arrange for initial consult? So that's exactly it. So please ask your GP to send in that referral, and that will initiate it. But John, in the meantime, you can still benefit from a lot of the stuff that we would ask you to try to reduce your body inflammation to help the nerve sensitivities, even if it was one of those neuromas. And so any of those group medical visits could be of great help for you. Okay, so Susan's asking here, says here, acupuncture, massage, chiro, tai chi, red laser, infrared, help in some way. I think what I'm hearing from that point is, do those things help in some way? And I'm going to say yes. And so what we try to incorporate, especially if, let's say you're starting to do some of your work with an acupuncturist or a massage therapist, our chiro does manual therapist. So I think the main point is this, is that all pain therapies have had obviously some benefits somehow, but not enough large amount of data is involved, because a lot of times it's not like, for example, a cancer drug a research study. There's a ton of money that goes into those things so that they produce all these papers and data, but we don't quite have that with pain. So my feeling has always been, if you take any therapy, it could be a drug, it could be my procedure, it could be infusion therapy, it could be massage. If you see after like 3 or 4 months, you've been doing it for quite, in a good recommended kind of frequency, and you're not getting anywhere, or you're actually getting more hurt, you've got to stop and relook at things. Or if you're kind of feeling, hey, it's good for me and it's good temporarily, then you make a decision if it's worthwhile of your time and money to keep doing it, to maintain. But know that if your benefit is so short-lived, you always should pull back and say, what else can be done to make that benefit more prolonged? I'll give you an example. I have often this right shoulder pain, partly because of all this computer work and my phone work, etc. And it happens to be right-handedness that really can get to me. And I do a lot of yoga, stretching, and all those things. And when that doesn't work, I get my colleagues, they needle me, bang, that muscle gets relaxed, and I can kind of do my thing. But I now do the nutrition part. I do the magnesium. I add to that. I do a lot of antioxidants. So I'm looking at all these things where I can prevent that from getting spasmed up. And so that's what I'm asking you, that if you're getting good but temporary relief with your massage, only good for a couple of days, maybe it's only for a week or two, you might want to consider you've got to load on a few more things. Okay. All right. So we have a couple of people here. You mentioned your clinic started the charity. So I was one of 3 people who started Pain BC. Yes. So it's not my clinic that did it, but yes, myself, Dr. McGrath, and Brian Warner, who is the previous department head of anesthesia. And that was 2005 when we started all of that. Donna says, TMS cannot be used if you have DBS. I believe that is the case, actually, Donna. The best person to ask are those who are the consultants who will do transcranial magnetic. They are quite different, and even with a DBS, it could be, for example, turned off, and then the transcranial magnetic is applied. It's very different, for example, if you had ECT, or if you had, let's say, a surgery that required what is called bipolar, and there's electrical signaling going on. So that's why I can't comment on exactly if TMS cannot be completely done if DBS is in place. All right, so a couple of questions here. My husband has extreme low back pain, and no one's been able to find a cause. Only helps him to be lying on the floor, gently moving arms and legs until pain lessens. Okay, so that, I'm so sorry that you're going through that. That is probably 70% of a GP's office's problem. And so again, I mentioned to the person here talking about low back pain, here's how we think about it. So when it's really severe low back pain, first of all, you have to rule out that's not fractures, not new onset infection, and there's no cancer. So then we expect that your GP has sent over those examinations and imaging to give us reassurance that we're not dealing with that stuff, because we're not the ones to deal with that. That's not the right action. But that having said, most common is going to be joint degeneration disease. It's going to be, let's say those muscles being so tight, it's been rubbing up those joints, and we now need to deal with your joints. We can't solve or cure them, but we can take pain away from them. Now, number 2 most common is that they actually haven't needled those muscles properly, and that they really need to free up. Your back is 4 layers of muscles, like a sandwich, and they need to get to the really deep stuff to really get the back moving well. And that's why your back gets relieved when you can just move the arms gently and just let the back rest. It's as soon as you stand up and activate things, it becomes a problem. So 3rd thing, maybe that back problem comes from a trauma where the ligaments are loose now. So now all the muscles are super tight to hold you up. So they're doing their job actually, but then you have severe pain because they're so painful and tired. So the goal there is to treat the ligaments, and that's where prolotherapy, which is private pay, comes in. So again, there's a few other things, because there could be back pain and bum, back pain in both legs, back pain and neck pain, back pain and headache. So all these variations are very different in my eyes, depending on how you present. Okay. So then I see here, back pain seems common in Parkinson's disease, Raymond says. Do you check for other conditions causing long-term pain, stiffness? Yes. So that's what I'm saying, is that now we rule out layer by layer. We don't just say, oh, it's Parkinson's, just rigid muscles. No, in fact, we test you. We even test to see how rigid those muscles actually truly are. Because sometimes that's the fascia. That's actually because it's been rigid for a while, and it hasn't learned how to move better. So we've seen some incredible new range of motion just by causing the fascia to change. And that's what trigger point injection work. But yes, the short answer to Raymond's question is yes. That's why we looked at inflammation. We look at your x-ray. So if your GP didn't send it, we got to look. If, let's say, someone's had a diagnosis very young, in their 30s, for example, I got to make sure that you don't have AS as your low back pain problem. Okay, we've got a few more questions. Briefly touch on dietary recommendations. Okay, so brief. I'm going to really try to be brief without talking too quickly that you don't understand. But actually, let me first share you the screen so that this at least you will utilize even when you have finished this talk. So I'm going to go back to the website. I want you to go into frequently asked questions, please. You will therefore go to, and these are, all types of questions get answered, but right at the bottom is called reducing systemic inflammation. Now, these are generic recommendations that are generally good for most people, Parkinson's or not. However, you have to individualize this, right? Not everyone's good with this. So I'll give you an example. So for example, a number of you who haven't thought about your microbiome, take a look at this Canadian website on basically your prebiotics, which are foods to feed your gut bacteria that are healthy. So that's one strategy on nutrition that's not traditional, but you got to look at your bacteria first. Forget the food, look at your bacteria first. Now, let's say you move on. You might move on to other things. So, for example, the antioxidant capabilities of your colored vegetables, your flavonoids, or your high-dose vitamin C, or your fishes that are omega-3 rich, right? So again, I'm using this question on foods, but directing it to the principles of why you're eating. So I never eat just to eat anymore now. I eat because I'm looking to pack my body with antioxidants. I look to shift, for example, I get a pain flare up with this, or it's my leg. I now look at not taking ibuprofen. I might use some Tylenol. I'll definitely open up into zinc. And there's only 3 types that you should be using for pain. That's your malate, bisglycinate, threonate. So those are just molecules hooked onto the magnesium. But when you look at the bottle, turn it around, look at the exact magnesium amount, because your bottle might say it's 500 milligrams, but the actual amount might be 50. So you now see in this recommendation here, oops, I keep touching it, it keeps going back, is that I'm asking for what is called elemental 250 milligrams. So that means when you turn around in the back, it shows that every pill contains 250 milligrams of magnesium. Okay, so just for those who've forgotten, this is on the website. It's frequently asked questions. It's the lowest tab right here, and you click it open. Okay, I'm going to stop sharing. So I have a few more principles. I talk about nutrition. And so you'll see, you'll see in a number of our group medical visits, we touch on this a lot for a variety of reasons. So under brain health, which is very much along the lines of Parkinson's, brain and nerve health, is we look at what is protective for nerves. So for example, your spectrum of your vitamin Bs, and those are very good also for your slimy layer, mucus layer of your gut. And you want that because you want that nice environment for your good bacteria to sit in there, lock in, and do its work. So again, many different principles about nutrition, but the one I'm leaving you with right now is around building an antioxidant regime. Flax seeds, chia seeds, omega-3. I eat sardines and mackerel for breakfast for protein and the omega-3s 4 to 5 times a week. And I will add this with my kombucha. I will take dandelion greens to feed my bacteria even before I eat anything else. So those are the things that we think about. Okay, so could you touch on anti-inflammatory foods? So David, I think I did touch on that there, but anti-inflammation is another separate thing together. So for example, turmeric is a spice, as you know, but it actually has some direct anti-inflammation properties. So antioxidant is how to think about it is, for example, when I have a pimple. So I have a pimple, it's really painful because it gets swollen, it gets red, there's a bunch of pus in there, because that's a very active part of the inflammation system. And it's going in there to repair, break down, and seal it up. And so ibuprofen, that's why it works. But I use things like magnesium to calm down the system because of pain in the muscles, etc., that you don't need ibuprofen for. I will use a higher dose of chia seeds around that time because I want to now rebalance how much inflammation there is. COVID is a good example. COVID, when it affected some people, they got some sniffles. But other people, it was like inflammation all over. Why? We don't exactly know. They're trying to kind of better understand that. But part of it is the system went overboard. So to the point of the knee problem with after surgery, that might be one of the problems, was the system stayed overboard and now affecting those nerves. So summary, that is just that briefing just on the anti-inflammatory foods, antioxidant. Okay, there's a hand raised in the audience. I will activate participants microphone. Yes, can you go ahead, please activate. And if you are activated, I can't hear anything. And keep trying, because I can just answer this question from Donna as well, as you guys keep trying to unmute. So Donna says, I have constant tingling in my right foot. Any suggestions until I get my nerve testing done? Okay, so nerve testing is generally the nerve conduction studies, and the fact that you just have tingling in one foot, makes me more think that, it could be affecting a nerve root, and in particular, if it's a foot, it may be L5, it may be S1. So in this regard, now tingling is very different from pain. Now, if it's just tingling alone, it's just really annoying, but it's not causing you big imbalance because your foot isn't weak, that's great to know, more reassuring, because it's then funny sensations. And sometimes, you can just get muscles released, and that could actually help, to be honest, because sometimes you just have a narrowing up above the foot, and that can cause that. Now, if you have a drop foot, or you're tripping, or you're really clumsy, you need to see someone more urgently. Don't just wait for that test. Get to the emergency department, tell them about it, because something's really compressing and causing quite significant weakness, not just tingling. Now, your tingling might be a result of a nerve root that's in the back. And this is where, if you see a pain specialist or someone dealing with this, they might do things like epidural steroids, or even something called dextrose, which is not using steroid at all, and to help alleviate any pressures there. And finally, obviously, anything that I just mentioned right now for good for the brain, antioxidants are always going to be good for your overall nerve health in general here. Okay, so Lois, your microphone, please go ahead.
Oh, no, I don't have anything.
Oh, okay, perfect. That's okay. Good to meet you. Good to meet you, Lois. And if anyone else wants to unmute, please, you're welcome to. And I think so Simon is putting another point through here. My feet get very sensitive, and while walking, the ground appears to be too hard. The bottom of the feet feel very painful. And sometimes it's very severe, and you almost get blisters. In fact, you get blisters. Bottom of the feet also gets very hot after 20 minutes, almost burning, hurtful, sometimes lasting up to 20 minutes. Can be due to PD. Never had it before. PD diagnosed 2016. Any suggestions? Okay, so the painful burning feet can be two things. As mentioned up above with Donna's question, it could be any of those causes. But also, when it affects both feet, it's also these additional causes. So there's small fiber neuropathy. So this is where, for example, if you might have some early diabetes, you might want to look into that. And I don't know if you've had any other kinds of diagnosis, for example, exposure to chemotherapy. Those things can cause damage to small fibers, and they show up a little bit later. Then there's something, if your feet actually turn red, you should observe that, actually, because if they're quite red, there's something called erythromyalgia. Almost exactly describes what you're talking about, minus the blisters. Blisters can occur just because you're walking too much or the skin is too fragile. So erythromyalgia is basically red pain, like when you define it. And that's a phenomenon related to the blood vessels. And so, yes, you should see your doctor about that. And they should send you over to a vascular surgeon to take a look at that. May be part of the cause. Now, let's say going through and finding out nerve conduction studies, there isn't anything compressing on that, then this is the realm of neuropathic pain. And if your neuropathic pain may be that just lightly touching, stroking the skin, not even walking on it, but just stroking it is painful, that is what is called allodynia. And that means painful skin. to touch, and it shouldn't be painful, but it is painful. And so we need to now take up some, more advanced therapies for nerve pain. In fact, I'm just going to type out a couple of things here. Let me see if I can do it to everyone. Yeah, perfect. I want to just give you some molecules to think about, especially if you're thinking more widespread pain, because these are what is called glial cell modulators. Okay, so another one is called okay, so that is PEA, that last one I just wrote. You might be considering the higher doses vitamin C, so vitamin C more into the 4,000 to 8,000 realm. So again, I'm just kind of writing down some few things that, so for example, with small fiber, with these more wider spread pain, it's not just one nerve root and one kind of thing that we can target. These are some things you might want to explore with your doctor. And because they target a different part of the immune system, not the ibuprofen targeting my pimple immune system. This is more like chronic nature. And these are normally the house cleaners of the nerves. So it'd be interesting to see how much of that might be of help to that. Okay, so Donna says, I have facet steroid injections. And what was the thing you mentioned that was non-steroidal? Okay, so this is what you may be considering instead. Because the problem with steroid is the following. Is that a steroid in general. So I've been traditionally trained with steroid, and it's okay, except that if you use it over and over and over, it will actually accumulate. And especially for skinnier or thinner bone people, you're going to have higher risk of osteoporosis. There is skin and muscle thinning. Ligaments are weaker. So if we can find alternatives that don't involve steroid, I'm always the first one to promote that. And I will use steroid. But to be honest, if you can find it, that's not try. So what I've written for you here is dextrose. Dextrose is essentially really just sugar water, literally. And here's the other thing is that Donna, for those who wrote down about back pain, your back pain might not be those facet joints only. They in fact might be nerve entrapments. And I'm going to show you, in fact, I'm going to show you a picture on this, this kind of mesh model up here. So you can see the buttock area just kind of over here. So you see the buttock clefts. So near there on most of you can feel your own kind of where the pelvic bones rise. You'd be surprised the number of people where the nerves called the cleal nerves that go right over that hump is actually trapped. Every nerve is in a tunnel. They slide back and forth as you walk and move and things like that. But when they aren't and they're trapped, because they get sticky, operations, or maybe it's inflammation, maybe you had an infection nearby, or maybe just because that's the way your body just laid down some tissue and they just decided to get a bit more stuck. And then so what happens with those those nerves being trapped, you're going to have a characteristic. Here's my low back, middle, and also to the side, into the bum, radiating into your hips. I would say at least 2 people in this audience are going to say, wow, I've got something like that. But that might also be your sacroiliac joints. It might be those facet joints that Donna's talking about. I have some people where their pain is just right at the lower part of the bum fold and in that back of the thigh. And they think it's only all in the spine. No, there's another nerve that gets entrapped, and that's called posterior cutaneous nerve. And again, that entrapment, once you open that tunnel up, you have this great relief. So again, you have to do things layer by layer. Okay, and Donna, yes, Donna. So that's why, so 2 things. I want to speak to this a little bit off topic from Parkinson's, but osteoporosis. So yes, first avoid the steroid, but I need all of us. It doesn't matter what age you are, wherever you can, try to weight train. Try to develop something that is related to resistance of some type, even little bits. And if you're curious, go to Men's Health magazine. If you look up weight. So weight bearing exercise. So you don't need fancy gyms. You don't need all those dumbbells. You don't need that. But of course, you're welcome to that. But you want to train muscles, train ligaments. And now it's more tough if you're really rigid. Okay, so I get that. But for those where you're not, you actually do want to train. And therefore, the final thing about nutrition, most of us do not eat enough protein to actually recuperate. You start looking at the amount of protein you've got. Example, fist-size steak is 30 grams of protein. If it was like, let's say, tenderloin. But the average adult body is about 150 pounds to 200 pounds. Let's say somewhere around there. That average size requires about 110 grams of protein. So this steak, to get that amount in veggies, you're like taking like 2-3 cups, or in legumes. So you can see the amount of protein is maybe not so much. Okay. So Anita says, do you recommend a diet? So that I can't right now, not just for Parkinson's. I think that's a great question. And that really stimulates me to look that up myself, because I was giving you a general approach of just your body's health, not just Parkinson's alone, because Parkinson's is that of the nerve, brain health and neurotransmitters. But the body's nourishment is consistent across cultures, ages. And so it's the stomach bacteria, it's the way you absorb, it's the way the liver, the kidney breaks things down. And that's quite separate from Parkinson's itself. And so thank you for stimulating that question, because I'd like to read on that as well. Oh, everyone, we are over time. We're 3 minutes over. Shelley, Elena, I don't know if you want to say a few things. You were excellent questions.
Thank you, Brenda. I just wanted to quickly go back, if you don't mind, to Simon's question about, so I think what he's referring to is that he doesn't actually have the blisters, but it feels like he has blisters. Is that something that goes back to having oversensitive skin?
Yeah, exactly. So like I said, in fact, in your case, it sounds as if you've got allodynia, which is even just light touch. But yours may be what is called pressure allodynia, only when you walk on it. Irrespective, it's abnormal. Pressure should be pressure, light touch should be light touch, pointy is pointy, cold is cold. None of that should actually cause pain, because you have different nerve channels and processing areas of the brain, and those signals don't cross over until they do. And when they do, that's a different story. So the first thing we have to do is always rule out, do you actually have something there? Like, do you have plantar fasciitis, right, Simon? Do you have inflammation in your joints down there? So you have to rule all those kinds of things out. But then finally, is it really not mechanical, but it's really neuropathic? And again, you've heard me answer the questions in a way that we answer it. And so for you, you might even need something like ketamine or lidocaine infusion to better understand how you respond to that. Because if you do respond to that, then we know most likely your nerves are driving that pain sensation. Yeah. Okay.
Brenda, I would like to thank you so much for such an informative presentation and for answering all of our questions. A lot of information there, a lot of helpful information. Thank you so much. And thank you everyone for attending and all of your great questions and participating. Did you want to say something, Brenda?
I do want to say one more thing is to Raymond, who raised an excellent point. I want to say that, first of all, thank you for the sensitivity of your comment, because I don't, my intention is not to be saying anything that triggers or makes people feel anxious. But I do hope that what I am saying empowers you, that knowing that now in BC, as compared to 5 years ago, if I did this session 5 years ago, we could not offer many other more layered ways of dealing with pain. No one wants to live with pain. And I'm just hopefully giving you some light that there are sometimes conditions in which they've been missed because we're not thinking about it a certain way. The nerves being entrapped, or maybe it's the, not enough vitamin C and the antioxidant capacity, but these are things that are in your hands and we could do something about it together. So that's really the intention of all the information I'm trying to share. And I am sorry if anyone does feel another way. I hope that if we can answer that differently, or if you do feel triggered or anxious, you know what, shoot over a question, maybe even join one of our group medical visits. But at the very least, please bring that up to your GP. That's going to be really important. Okay.
Thank you so much.
Thank you,
you
everyone.
so much.
Yeah,
It
you're
was
welcome.
so good. Really
You're welcome.
appreciate it.
Thank you, Brenda. Thank you, everyone. Have a great afternoon. And remember, check out our website and register for Superwalk.
All right. Very good work, Elana, Shelley.
Thank you
Bye,
again.
everyone.
Have a great afternoon. Bye, everyone.